Assalamu alaikum everyone. Very warm welcome to you all from Mubahith. It is a privilege to introduce our esteemed speaker, Ms Quratul Ain, a consultant oncological breast surgeon and Guy's and St. Thomas NHS Foundation Trust, UK. She specializes in the surgical management of breast cancer, skillfully combining oncological and reconstructive techniques to achieve the best clinical and aesthetic outcomes. With extensive experience in managing both benign and malignant breast cancer, breast diseases, and a strong commitment to disciplinary care, education, and evidence-based practice, she brings a highly valuable perspective to today's discussion. We are honored to have her with us today's session on navigating Mastalgia pathway. So, without further delay, let's welcome Ms. Quratul Ain. Over to you.
Assalamu alaikum and good afternoon and good evening, everyone. Thank you very much, Mubahith, for inviting me for this talk today. So I'm going to share my screen. So a very important topic, not much discussed, but we come across the patients presenting with breast pain every day in our clinics anywhere in the world. So we are trying to have a look in this next half an hour to see how we can manage these patients in the best possible way. We will talk about the epidemiology and the impact of patients presenting with breast pain, the types and etiology, the investigations and managements that are done, and the current Association of Breast Surgery or ABS recommendations. In the study of the disease of the breast, pain is frequent, yet seldom a matter of serious disorder. I think this summarizes what we are dealing with in everyday clinics. If we look at the literature, the first breast pain description goes as far as back as 1829. And today we know that about 70 to 80% of women will experience breast pain at some point in their lifetime, which, as you can see, is quite a significant number of women. 40% report effects on sexual activity, 35% on the sleep, and 5% affects their work activity. About 1 in 4 women with breast pain have moderate to severe pain, and it lasts more than 5 days. It leads to anxiety, depression, and fatigue. With ever-increasing exposure to information and education, which is what we want, but it also has a caveat that it leads to anxiety in women about cancer, and it makes it one of the most common presenting symptoms in breast clinics. In addition to the impact on the patients and their lives, it has significant economic impact. I'm sorry about that typing error. Impact on our systems in any country. The breast pain is commonly described as cyclical, non-cyclical, or extramemory. We're just going to try and understand these presentations. The cyclical or physiological pain is intermittent, likely recurrent, and related in time to the menstrual cycle. Women experience these symptoms mostly on both sides, on the upper outer parts of their breasts, and it's a recurrent presentation for them just before their period. However, saying that, breast pain can still be unilateral or asymmetric. Patients I see in my breast clinic, I tell them that breast pain comes in every shape and form, but its significance doesn't change. Now, why does breast pain happen with the cyclical changes? We may not know the exact pathways, but there are 2 most common explanations for the pain. It typically occurs in the luteal phase, and as we know, breast is an histological organ and it changes throughout the cycle. In this phase, there is rising progesterone level, which leads to increase in the lobule size and terminal ductal units. There is proliferation of the basal epithelial cells, which leads to stromal edema, and that gives the symptoms of breast fullness and venous congestion, and that can explain pain. We do have radiological evidence of these changes, that on MRI, there is increased T2 signals, which basically is showing increased stromal edema. So this is one explanation of why women have pain in this particular part of their cycle. More recent studies show that the sex hormone binding protein is responsible for this, as it has been positively associated with increased percentage in breast tissue, and that may explain pain. Either way, we know that this is because of the hormonal changes. As opposed to the cyclical pain, we have an entity called non-cyclical pain. And majority of this pain is benign. Up to 4% of patients may have associated breast cancer when they present with non-cyclical breast pain, when there is absence of any other symptom. The causes of this are mostly idiopathic. We may not know why the patients are having this non-cyclical pain. It can be related to inflammation or infection. Inflammatory causes can be chronic, such as granulomatous or non-granulomatous mastitis. There can be lumps in the breast, benign lumps such as fibroadenomas, that can lead to pain, especially if they are increasing in size. Hormone contraception of any kind can cause to pain, and other medications can cause pain as well, such as antidepressants and antipsychotic medicines, such as SSRIs, cardiac medications such as digoxin, and antimicrobials, certain antibiotics and antifungals such as metronidazole and ketoconazole can cause pain as well. The most common cause is the simplest, and yet it is significant, is ill-fitting underwear. So ill-fitting bras or insufficient breast support is a major cause of breast pain. I would actually not call it a cause, but if someone has sensitive breasts or a lot of changes in the breast because of hormones, if they are not using the right supportive underwear, it just exaggerates it and delays the recovery from this episode. So it is very important. Now I will talk about certain groups where we will have non-cyclical pain. Important of these are perimenopausal and postmenopausal women. These group of patients would have, especially perimenopausal women, will have elevated and erratic estradiol levels, which lead to symptoms. And this fluctuation of hormone spikes is very common, especially these days, as more, like I said, with more awareness, more education, and more exposure of women to perimenopausal health information, more women are using hormone replacement therapy, so HRT. When women are using these, they may have more presentations of breast pain. Or it could be extramammary in origin. We have to investigate to rule out any underlying disease, and reassurance is very important. You will hear this word many times today in this presentation. Then we have another group of people who will come to our clinics who are pregnant or lactating, and they will present with non-cyclical pain. Again, hormones are the underlying cause. Estrogen and progesterone secretion increases substantially during pregnancy and lactation. It increases the breast tissue volume and increased vascularity. There is fullness, there is pain. Although it is not going to lead to any particular problem, but related to breastfeeding, we have to be aware of certain other associated presentations, and because they may need a little bit more treatment and reassurance. The milk stasis or engorgement leads to symptoms. There can be fungal infections there can be nipple eczema, there can be trauma from the act of breastfeeding itself, there can be dermatitis or viral outbreaks, mastitis or abscesses. So even though the patients do present with pain in breastfeeding or during pregnancy, but we have to make sure there is nothing associated with it that needs little bit of more treatment and attention and follow-up. Coming to the next form of pain in the breast, which is extramammary. Now, as the name suggests, it is a pain which is originating from sources other than the breast. So truly, it's not a mastalgia. But we do see patients because the pain is in the area of the breasts, and we end up seeing them as breast clinicians and breast surgeons. It is the most true common of non-cyclical breast pain, and the causes are various. To name a few and the common ones, musculoskeletal pain, costochondritis or teeth syndrome, which is a specific form of costochondritis and happening in the second and the third intercostal space. Trauma to the chest area leading to the referral pain. And when I'm talking about musculoskeletal, in perimenopausal and postmenopausal women, osteoarthritis of the shoulder, of the back is very important because it leads to referred pain. Other medical conditions that do present as chest pain, like I said, in the area of the breast, that are not originating from the breast itself are esophageal, gallbladder disease, respiratory disorders, and heart disease. So we have to carefully investigate by history and examination in our clinics as to where the pain is coming from. Now, how do we investigate these patients? I would like to ask a question. Is triple assessment needed for all? We do know as breast clinicians and surgeons that triple assessment is the word we commonly use in our practice. Whereas we are talking about taking a full history and doing an examination, doing certain radiological examination and getting an histological diagnosis. So do we need to do a triple assessment for breast patients? I've put a question mark here, which is very important. And we do not need to do a triple assessment. We have to evaluate these patients, but we do not need to do all components of triple assessment after our assessment. So to begin with, like any other patient assessment, you have to take a complete history in order to make sure you are considering all the causes of breast pain that we have talked about in the previous slides. If it is breast, then what is associated with it? If it is not breast, then what is the cause? So complete history is very important. Breast and axillary examination, that is the next step, and that reaffirms what you have found out from your history. Imaging is only used or should only be used when indicated, although we do overuse at times this modality or this part of triple assessment, but it's not always indicated. So we have to perform imaging when it is indicated. According to the Royal College of Radiologists and British Society of Breast Radiology current guidance, patients presenting with breast pain only, either generalized or focal, are not routinely offered imaging to investigate these symptoms. If there is separate clinical concern regarding a pathological etiology, patients should have access to imaging in a timely fashion. So this is very important. So we have to make sure when we are seeing these patients that routine breast cancer screening is up to date. Mammogram and ultrasound are used based on age and presentation. Now this is going to be a bit variable and depends on where you are practicing. Breast screening age is different in different countries. And also is the use of the mammograms in assessment of women around a certain age. In UK, majority of one-stop breast clinics, that's the clinic that we call where a patient presents with a breast problem and we do the triple assessment, which means doing the history, examination and imaging and biopsy in one go. So in the UK, in most centers, although it differs even with the UK, but majority, if a patient is 40 or above, we will do a mammogram for them and only add an ultrasound if there's a focal tenderness. Women younger than 40, if there is a focal tenderness, an ultrasound will be done. Otherwise, it will be just clinical assessment. Now, it's very important when we are talking about this. When you are seeing a patient and you find out on their history or on their clinical examination, and you find there is some other important sign like skin changes, lumps, palpable lymph nodes, any of the symptoms, any of the signs that patients may not have noticed themselves, but if you find that, then you're going to deviate from the breast pain pathway. You will going to leave the breast pain pathway and you're going to investigate that sign because that is going to be more important. So practice is going to differ in UK, in Ireland, Europe, US, Asia, or Middle East. Wherever you are practicing, you have to follow your local guideline. But important thing is that you make sure there is no associated sign that needs investigation. There is no data supporting use of MRI of the breast in investigating the breast pain unless there is another sign that you are trying to investigate. Now, these are the two important things which I would like to add, that there are studies which show that if we were, and also you can, without even data, you can tell that if you do an ultrasound for a woman or a mammogram and tell them it's normal, and even though they come with the pain, they go back home quite reassured. So negative breast imaging helps to reduce patient anxiety and provide reassurance, and there is data to support that. However, studies show that doing this is already contributing a huge burden on the health economics. So there is an overutilization of healthcare resources, the resources that we can use for women who need these investigations more. So there is a balance that you have to strike, and every clinical system, health system, is trying to find the best possible way to deal with this. So now we know that what is causing the breast pain, what are the common presentations, and what is the investigation. So how are you going to deal with these patients? How are you going to manage them once you have made the diagnosis of breast pain and ruled out everything else? So we're going to talk about a few things here. Conservative measures, diet and lifestyle changes, analgesics, hormonal treatment, and surgical intervention. So this alone deserves a slide for its own right. It's reassurance. This is the most important thing that you can do for these women. You have to reassure them. And it's not just that I'm saying that, we do have data to support this. Cyclical breast pain resolves spontaneously within 3 months in 20 to 30% of the women. And non-cyclical breast pain may resolve in about 50% of women. And reassurance effectively treated in this study about 86% of patients with mild pain, 70% of patients with moderate pain, and 50% of patients with severe mastalgia. That is very, very significant and underrated. I have put down the references for these studies in this slide itself because I feel that it is very important. For the rest of my presentation, obviously I've taken information and references and I can provide you with them if you need. But this is very important, reassurance. So next time when you're in the breast clinic and you are reassuring your patient, just use yourself should be reassured that this is scientifically based. You are doing the right thing. You are not doing something which is inferior to medication or surgery. The next thing, again, very important, is well-fitting bra. So like I said, ill-fitted underwear is not causing the pain itself, but in all cases, but it does delay the recovery. It does make it worse. So it's very important, especially in women with large breasts, especially in women, regardless of the breast size, if they are active, physically active. Because the right size bra is going to support the ligamentous structures and reduce the movement of the breast, reduce the amplitude of breast displacement during walking and running. So if someone is physically very active, they go to the gym, they have a very active lifestyle, it's very important that they're wearing the right support. Women who are large breasted, again, it's very important for them. So you will be surprised by the number of women who will come to your clinic, and if you ask them when was the last time they had a fitting for a bra, you'll be surprised that probably never or many years ago. So it's very important as the bodies change, they may need to change their bra size. It's not one size fits all or one size fits all of your life. So there are other things that we do, all of us talk about when we are talking to these patients, the conservative management measures, exercise. So exercises do help, obviously, if it's to a certain degree, although we have to be careful, then doing severe exercises and severe pain can exacerbate it, so it has to be a balance. Smoking cessation is important. Evening primrose oil, the use of it, and caffeine reduction. Now, all of these measures, I have not put in separate slides for these or put in references because we do not have good quality data to support this, but they may make a difference. So there's no harm in talking about them. And they do have overall health benefits like exercise, stopping smoking, reducing your caffeine, and using evening primrose oil. So some women may find it useful. Some women may not, so there's no harm. Pain medications, anti-inflammatory such as oral or topical, both have a role. So you can try and see, depending on what the patient can tolerate and can take, you can try these medications, starting from the simpler pain medications such as paracetamol and ibuprofen. I came across this table and it's very interesting. And you can see in the first study, again, I can provide you with the references or links for these studies. These are all RCTs. And as you can see, the first one was a comparison of danazol with sports bras. And you can see the sports bras can relieve mastalgia. So something very supportive measure and not a medication is equally or even more beneficial for patients as opposed to medication that have their own side effects. And general dietary advice versus low-fat, high-carbohydrate diet, which was the intervention. The significant reduction in severity of premenopausal breast tenderness and swelling in intervention group. So you can see low-fat, high-carbohydrate. So diet modification can help. Exercise versus control. Exercise treatment is beneficial for patients with mastalgia. So we do have studies, not big, but we do have enough evidence to support about lifestyle changes, about using the right size bra, and being active. Now, hormonal therapies. With the advent of all this awareness and access to information for our patients, you will have patients who are well-read and they will come to you and ask for specific management, specific treatment, specific medications. So you have to be, so first of all, be aware of them, be well-versed, and then you should know when to give these to the patient because there are only very limited indications when you can truly move to these medications for breast pain patients. So it has to be very careful consideration and a discussion with the patient. So danazol is one, and you can see it's a third line agent after you have exhausted and used all of the measures. It's an LH and FSH inhibitor. It binds to the sex hormone receptors in target tissues and results in anti-estrogen effects. It decreases the cyclical breast pain. The side effects include weight gain, irregularity in the cycle, nervousness, changes in the voice, and androgenic effects on the fetus. So you have to be very careful and have an open discussion with the patient if you are going to prescribe these medications. The next is tamoxifen, and we are more familiar for the use of tamoxifen for cancer patients. So it's a cancer treatment. It is limited availability, it is expensive, and it has side effects. So again, be very careful if you are considering this for patients with only breast pain, and only if the rest of the measures have been tried and they have not worked, and you have ruled out every other cause of the pain. So just a little recap for our memories, that it is a selective estrogen receptor modulator reserved for severe breast pain, and in studies has shown to reduce the pain by 70 to 96% in women with cyclical breast pain and 50% of women with non-cyclical breast pain. And if you are considering use it for limited time periods, such as 6 months, to see how it is working for your patient. Considering side effects is very important. And as we know, tamoxifen leads to increased risk of DVT and PEs and endometrial cancer. So very important to consider and discuss with the patient. Then there are gonadotropin analogs, which are again inhibitors of pituitary gonadotropin secrete, decreasing the production of estradiol, and again reserved for severe refractory breast pain cases. There's another table which is interesting and informative, where different medication groups have been assessed in RCTs. As you can see, these are small RCTs, not big studies, but there are obviously results which can help our discussions. The first one is danazol 200 milligram versus tamoxifen 10 milligrams versus placebo. And you can see that danazol and tamoxifen both reduced cyclical pain as compared to placebo, and there was no significant difference between these two. Then the other one is tamoxifen versus placebo. In 3-month follow-up, tamoxifen was more effective in breast pain. Then there is bromocriptine versus a placebo, where bromocriptine was more effective. And topical NSAIDs like diclofenac versus placebo, where diclofenac was more effective. So we can see that these pain medications have reduced the breast pain as compared to placebo. But again, we have to consider, even when we are looking at the published data, that these are small studies and the follow-up is small. We do not know what were the long-term side effects of these medications for these patients. So it has to be a very careful and educated and an open discussion with the patient when you are considering these medications. So what is the current ABS guideline? The reason that I'm telling you about current ABS guideline is because that's what I'm practicing. And you can go and look up what your local guidelines are. But there are similarities in guidelines across the world for most of breast problems. So there are various pathways, even in the UK, which are being explored as we speak to reach to the most effective solution. The main reason for looking for a most effective solution is the economic impact and the burden on the system of patients who come to the one-stop breast clinics with only breast pain. So at the moment, ABS has an ongoing, you can say, study or project called Aspire. You can look it up on their website, where they are exploring how different pathways can work. Different trusts in the NHS are working on these pathways, and hopefully in near future we will have a unified and effective method. I'm just going to go through different pathways which are being practiced. These are in addition to the patients that we see in the one-stop clinic. So there's a telephone breast pain clinic where the consultation is done over the phone itself. There is no physical appointment. And for women who are 40 or above, according to the local protocols, they are called as to have a mammogram, but not on the same day. It will be like an elective outpatient mammogram. Then there is a dedicated breast pain clinic in some trusts which are up and running, where a face-to-face clinic is done. But the one-stop imaging, which is the imaging on the same clinic appointment, is not done and only offered as an outpatient and as needed, like a mammogram if you're 40 and an ultrasound only if there is a focal abnormality or focal tenderness found. Then there's a GP managed pathway, which is in the community. There is no access to imaging. And if clinically indicated, then a referral to the breast clinic is made depending on the local protocol. So the GP manages the patient initially and refers them to the breast clinics needed. Self-management, in which the patient information is sent out to the patient following receipt of the referral. There is advice and guidance for the patient in there, along with an opportunity to request an appointment if their ongoing concerns are not settling within a given time frame, usually 3 months. So if the woman does not have any improvement in her symptoms after following the advice, in 3 months, they can request an appointment so that further evaluation by a clinician can be done. Then there is imaging only, where there is no clinical encounter. The patients are either we talk them over the phone or by contacted with a letter, and a mammogram is arranged for them, and nobody examines the patient. So there are different pathways being explored. So I would urge that all of you should look into what is being done in your trust or hospital locally and how things can improve. Now we will talk about a couple of special scenarios and considerations. As pain in men, not very common, but we do see men in our clinics which are presenting with pain, and it's usually men who develop gynecomastia, secondary to medications, hormonal imbalance, cirrhosis or other conditions. So basically they develop gynecomastia and then they have breast pain, and then when you are seeing them in the clinic. So the aim stays the same. First of all, you will take a full history, do an examination. You want to rule out what is the underlying cause. You will do the imaging, which is to rule out the disease in the breast tissue itself. So if they have gynecomastia, if they have breast symptoms, and if they have breast pain, we need to make sure there is no other disease in the breast. So imaging in the form of mammogram or ultrasound, and every hospital will have their own protocol. Every radiology department will have their own pathway that they follow. So you do the imaging. You want to make sure there is no disease, and then you will reassure and then manage the underlying cause. For example, if it is alcohol excess, if it is medication, so that needs to be managed. Then there are patients in the breast clinic that you see who have previous history of breast cancer. It is very important because in these patients, we can't just ignore breast pain, because pain may herald some other, problem, or it may be related to a recurrence. So you have to be very careful. If someone has a cancer history, they require full workup to rule out cancer recurrence. So you take a full history, you do an examination, but even though the most common cause in these patients is the post-treatment changes, the surgery, the scarring from surgery, and the radiotherapy, or if they are on medication, hormone manipulation after the adjuvant setting, like letrozole or tamoxifen. So they can have pain, but you have to be very careful. You have to make sure you rule out. So you may do additional imaging for them in the form of chest X-ray, CT scan, bone scan, PET CTs, depending on your local unit practice, to make sure there is no local recurrence or any distant recurrence for these patients. And if everything is clear, then obviously you will reassure the patient, because the most common cause would be their treatment that is causing the pain, but only after you have ruled out the cancer recurrence. I've not added a slide here, but I think it is important to talk about these days about pain in cis and in trans men and women as well. If someone is taking hormone manipulation and if they have breast tissue, it can lead to breast pain. So it's very important when you are taking history and doing examination that you rule out the underlying causes. And essentially the imaging is also done depending on your examination, and the most common cause will be the hormones, and you have to reassure the patients. So you may come across patients as well who are on hormone manipulation. So I'm going to conclude what we have been talking about. You may have noticed that I have not added a slide about surgery when I was talking about treatment. So even though I'm a breast surgeon and I love to operate, but surgery is not the treatment. So even though we do mention it, but it's not something that we talk about because it's not needed. Surgery may be needed for underlying causes. For example, if someone has an abscess, you drain it. If someone has a lump, you deal with it. But it is not a treatment of breast pain, not in my practice, and not advocated by any guideline. So something to remember now, a few nuggets before we finish, is breast pain is benign. It is rarely related to cancer. You need to rule out underlying or related disease. Reassurance is the mainstay of treatment. The non-medical measures are more important than drugs. Hormone therapies are only for extreme cases after careful consideration. Surgery is not needed for pain alone. There is no one pathway, so each system has to work out what works best for them. And education is the key. Educating the patient to be breast aware, educating the breast clinicians to know what to do is important. Thank you very much. That is my email address. If you have any questions, if you want references on any of the figures that I have quoted or any of the facts, please get in touch and I can provide you those.
सर आपका माइक ऑफ है.
Okay, thank you once again, Ms. Quratul Ain. This was a very nice presentation and very informative one. Guys, if you have any questions, please ask by raising your hands. You can ask the question directly, or just you can type in the chat box and we can ask for you. So there's a question. What are indications of hormonal treatment? And in practice, what is better, danazol or tamoxifen? Both are third line. So what is better?
So I think I did mention that we do have studies to suggest both are fine. Both have equal efficiency. You have to consider the side effects and availability. So which patient you are dealing with and what is the patient comfortable with in accepting the side effects. So it depends on what you want to do and what your patient wants to do. But efficiency-wise, they're both similar. And indications of hormonal treatment only when everything else has failed. So it's not for every patient. That's not the first thing you start. You have to make sure you have done the conservative measures. You have to make sure you have offered them simple and strong painkillers before you move on to hormone manipulation.
Okay, I think what she wants to ask is that you have a patient who has mastalgia and she fits for the criteria for treatment by danazol or tamoxifen. What would you do? What would you do? What medicine would you suggest?
Okay, so again, I would discuss the side effects because both medications have slightly different side effect profile. I will discuss with the patient what they are accepting of, and also what is their, for example, if someone has a history of PEs or clots in their personal history, in their family history, I would avoid using tamoxifen in those patients. If someone has a history of endometrial cancer, I would avoid using tamoxifen in those patients. So I would go for danazol first. So it will be it's not one answer for every patient.
I hope you get the answer, Dr. Nilofer. There's another question. Can fibrosis post-trauma to breast or surgery causes pain? In a patient who has tendency for keloid formation, is there any link of these both?
Yes, that's what I said when I said after surgery, after cancer treatment, if treatment of if even if not is cancer for benign causes, if someone had surgery for even for post-trauma or surgery, it can cause pain. Yes, and it's very much benign. So your approach will remain the same. You want to make sure you do the appropriate imaging depending on the age of the patient to make sure there is no underlying disease. And you will treat with the same conservative measures and painkillers. So it is very much present post-trauma and post-surgery pain. And in a patient who has tendency for keloid formation, is there any link? Again, keloid formation is a form of scarring, isn't it? So if patient has keloid, so you will deal with it like you will deal with any other keloid in anywhere else in the body. The treatment of keloid is the same. It's not like any keloid after surgery with steroid injection or whatever you are doing for your keloid.
Yeah, topical steroids, silicone gels, and steroid injections, etc.
Yeah.
Okay. Regarding this evening primrose oil, there has been a controversy recently that people are stopping to use it. They're not trying to use it as a first-line medicine because there are evidence in favor of it and against of it. So what do you suggest? Should the patients be given these treatments, vitamin E and evening primrose oil?
Yeah. So there is no harm in using, but if you are using it for the purposes of breast pain or breast symptoms, then you should use a high dose and you should use it for at least for 2 to 3 months in order for someone to know whether it works for them or not. So you have to take a higher dose and you have to use it for a couple of months. If it works for you, it's good. If not, you just stop it. So that's what I tell my patients. If they want to use it, they should. But it has to be used in a higher dose. It has to be used for a few months to know whether it works for them or not. Because it's not like a pain medication where you take a paracetamol or ibuprofen and you will know in half an hour or an hour if it works for you. These are just vitamins, so they have to be in your body for a certain period of time before you know if they work for you.
There was a point somebody has asked me that there was regarding mammography. You just said, I would like to clarify this because I think you were talking about the age where mammography starts, not the screening for breast cancer.
Yes.
Yeah,
No.
okay. Yeah, so it was 40 years for mammography, and I think in UK for screening mammography, it's 50 years of age
50.
and every 3
Yes.
years.
So no, it's the two different things. Sorry if it was not clear. So screening in every country is different. In UK, it is 50 years and above will have screening regularly. In symptomatic clinics, if someone comes who is 40 years or older, we do a mammogram for them. So it's different in
Clears
different
it.
countries. Yes, even for
And
symptomatic, even for screening.
in a patient
The
with
age is
focal
different.
tenderness, you would go for imaging, and if it is generalized tenderness, you won't go for that.
Yes, because basically ultrasound is a modality which is used for look at a focal abnormality. So if you have a focal dense area which is tender, you can do an ultrasound scan of that area.
Okay, so we have another question in the chat box from Sandaleen. How frequently mammography screening be repeated? Again, screening
Now that
mammography is related to cancer, I think. So, what's the protocol in UK?
So it again depends. Screening is something which is a national program in every country. It's different. In UK, it is every 3 years. Once you turn 50 until the age of 71, it is every 3 years.
Yeah, and recently in KSA, they changed the age limit. They started at the age of 40 years and they're doing it annually. So every country has a different
Every
guidelines.
country. It's more of it depends on the health economics, what everyone has, can afford or. In UK, they are doing studies and a trial to start it sooner, but at the moment, that's what is being practiced. Now, there
One more
is a
question.
question. Are there any
Are there?
subtle
Yeah.
features of mastalgia that should still prompt concern for malignancy despite normal imaging? It's not features of mastalgia, it is I would say, associated features. For example, if a patient has come with a lump and there's pain and there is skin or there is nipple discharge, or there is nipple retraction, there is skin dimpling, there is red breast, which looks like inflammatory cancer. It's not the type of pain, it's the associated features.
I mean, it's good to see a lot of participation from the audience, you know. So if there's any
Like
other
you said,
question,
it's something that everyone,
yeah.
and nobody has a right answer. That's the thing.
So do
So
whatever
it's a
suits you.
lot about how you cater individual patients based on their individual history and examination.
So any other, what do you say, a cheat sheet or something to treat nostalgia?
So over the last few years, what I have learned is that I was not using reassurance enough. Reassurance and ill-fitting bra, right size supportive wear. That is very, very important, because you will see patients who will come to the clinic, and when you ask them, okay, when was the last time you had a size of your bra done, or they would say never, or we don't wear a bra. So it's very important, especially if you are active and if you are physically active, and all of us are physically active. We are walking around. So if you're not supporting your bra, and if your bra is sensitive because of for whatever reason, especially when you are in the perimenopausal age or in young age, going through the cyclical changes, it's completely underrated. So that's what I felt, that I was not using this advice much, and now I have a proper discussion with my patients, and I add them in my letters and in my advice that this is something they have to consider. It's not about they will take a pill and it will go away. They have to actually take certain measures that will help.
Okay. So by ill-fitting bra, you mean it should not be tighter than normal and should not be loose than normal, right?
Yes, ill-fitting means it has to be the right size, it has to be supportive. It should not be loose, it should not be tight. It should not be tight that you can't breathe and itself is causing pain, and it should not be loose that there is a lot of movement of your breast when you are running or when you're walking, and because that is going to cause pain. So it has to be just the right size.
So we have two more questions. What is the recommended dose of evening primrose oil and vitamin E?
So for the evening primrose oil, it is up to 250 to 360 milligrams.
Yeah,
And like I said, you have to take it for 2 to 3 months to know whether it works for you or not.
that's right. So the next question, if a patient has strong family history of breast cancer in maternal side, so how can one go about screening early in her life apart from physical examination? Should they get their BRCA screening done or early ultrasound imaging be taken by them as for screening? Kindly enlighten about that. So this is not the topic, but still, if you want to answer that.
Yeah, so again, I wouldn't be able to answer that in a one word, because it a lot depends upon the age of the patient, uh, age of the person who had the breast cancer. Like they said, family history of breast cancer in maternal side. So how many people had breast cancer? What were their ages? What is the age of
From
the person we are talking about who is asking this question?
first degree or second
And
degree relatives and
yes,
how
and
many?
then
Yeah.
again, it depends again on which health system you are working. For example, if you are working in a private health system, you can have everything done. You can have yearly mammogram, you can have BRCA screening done. But if you are in a system like in the NHS, there are very strict indications of BRCA testing. Not everyone is offered. And if you want screening, again, there is a strict
Protocols,
criteria
yeah.
you have to fulfill. So if you want to look at those guidelines, there is NICE guidelines, have guidance about that. But again, like I said, if you're working in a private system, you can have anything.
And these nice guidelines are actually not very nice if somebody wants to do it by herself.
Yeah, so we
Uh,
can maybe talk about them on genetics or family history of breast cancer in another talk.
yeah. Uh,
Yes, you're right. They're not very user friendly, but we can talk about it on that day maybe.
means there's no direct recommendations regarding early screening. No, there are recommendations about early screening. If there is a clear-cut indication of getting early screening, that means your family has one of your first degree relative that has less than 40 years of age, breast cancer, two maternal side relatives, they have breast cancer, then you go for genetic testing. And then after that, you can go for screening also. By the age of 29 years, the screening starts with MRI and then, ultrasound and afterwards mammography and things like this. So there are recommendations, but you have to read them from NICE guidelines. There are full-fledged recommendations. It may take one complete lecture for this. So we have another question regarding evening primrose oil. It is 250 to 60 mg per day. In Pakistan, we have 500 mg and 1 gram preparations available. So it is 1 gram, sir.
Yeah, so you should take 1 gram. You should take whatever higher dose the patient or you can have. It's all about taking a higher dose. So 250 to 300 milligram is usually recommended on the evening primrose oil that on the bottles that we get here. But you can take up to 1 gram daily, but you have to take it. The main idea is to take it higher dose, and you take it for 2 to 3 months. In addition to everything else that we have talked about. Evening primrose oil is not a wonder drug, but it will give you better skin and better hair in addition to this.
Enormously, research evidence does not support it. So,
No.
yeah. So, are there any more questions? You can raise your hand if you want to ask the question directly. Okay, I think that's about it. Thank you, Ms. Quratul Ain. This was a wonderful lecture and wonderful webinar. And I'm happy that a lot of participants, they did ask their questions, they did ask very pertinent questions. A special interest is about evening primrose oil and screening. So these are important questions that needs to be answered, and that's why people who are not breast surgeons and general surgeons and breast physicians who are dealing with such patients, not even surgeons, I mean, in general OPD, patients come with these symptoms and they have to, move in circles and circles and they're still there with pain. So this was a very important topic for us, and thank you for being here for such an informative talk.
Thank you so much for inviting me. I really enjoyed the questions. And again, I will tell to Mr. Ridwan Taj, because he wants a very particular dose. So the reason that we have talked about so many doses because nobody knows what's the magic number. So I would say if you have the higher dose, whatever higher preparation you have available, use the higher dose and use it for 2 to 3 months and see if it works, in addition to everything else.
Yeah. So we come towards the end of the webinar. I would request everybody to please turn your cameras on so we can take a selfie. If that's
I'm just
okay with you
writing my
guys.
email in the message as well. If anyone wants to ask anything, any references or anything, please, you can contact me on my email.
Okay, I think I should take the selfie now. So please, everybody say cheese.
Cheese.
And we have the selfie with us. With your permission, I will be posting this.
Yes, please do. I would love to see everyone who was there.
Just a sec again, I think. One more. So everybody please say cheese again. We have some more participants. Okay, that's it.
Perfect.
Thank you once again. Thank you everybody for being here and being part of this informative webinar. We look forward to see more webinars from Ms. Quratul Ain in future, and we welcome you to Mubahith forum once again. Inshallah, for the next pink ribbon activity or any other webinar from Mubahith.
Thank you very much. Good evening, everyone.
Thank you.
Hafiz.